Dear audience, my name is Regina Molnár, and I would like to introduce you to our projects in the context of new insights into the development of abnormal glucose tolerance in cystic fibrosis. I'm a PhD student, and my supervisors are Andrea Párnicki and Klementina Ocskai. My vision is to achieve better life quality for CFRD patients, and my mission is to provide new screening strategies for earlier diagnosis. Here you can see our two ongoing projects, which are strongly related to each other and investigate different risk factors of early onset CF-related abnormal glucose tolerance. With the first one, we are focusing on pancreatic islet autoantibodies in a form of a systematic review and meta-analysis. Why did we choose this topic? Because CF-related abnormal glucose tolerance is the most common extrapulmonary complication of CF, affecting 1/3 of adolescents and half of the adults. Besides worsening the life quality of the patients, it significantly increases the overall mortality rate. An endocrine dysfunction of the pancreas can begin in early childhood or even at birth, and this is mainly due to physical damage to the pancreas with bystander beta cell death. But with destruction to the beta cells, autoantigens are released, which activates the immune system and can drive the development of an autoimmune setting. In type 1 diabetes, the role of islet autoantibodies is well established. According to the TEDdy study, 34% of children with islet autoimmunity develop diabetes in time. However, screening for such antibodies in CF is with limited recommendation, therefore not commonly used. Because of this, data is missing about pancreatic islet autoantibodies in the CF population, so with our first project, our aim was to determine if they contribute to the development of an abnormal glucose tolerance. We studied CF patients with a measurement of pancreatic islet autoantibodies, and their main outcomes included the presence of the listed islet autoantibodies, including any and multiple positivity as well, and the age of onset of an abnormal glucose tolerance. Our hypothesis was that islet antibodies are present in a significant proportion of CF patients. We conducted a systematic search in 4 databases and a forward-backward citation chasing, and finally 20 studies were included in the analysis. Prevalences and odds ratios were calculated with 95% confidence intervals, and here you can see a list of the analyzed outcomes. So let's move on to our results, and this first aggregated forest plot, which shows us the pooled prevalence of islet antibody positivity in people with CF. The most frequently screened antibody was GOD, and the least frequently screened was zinc transporter 8. High heterogeneity was observed in most outcomes due to 2 outlier studies with a technical issue in antibody measurement, and risk of bias assessment revealed that more studies had a high risk of bias. The prevalence of islet antibody positivity ranged from 1 to 6%, with lowest prevalence for islet cell antibody and highest for insulin antibody. Having any kind of positivity had a prevalence rate of 4%, and multiple and positivity had lower prevalence rate with 1%. So in general, the prevalence of islet antibody positivity was low in people with CF. We wanted to assess the prevalence by glycemic status, where we divided patients into diabetic CFRD and non-diabetic non-CFRD subgroups. The heterogeneity was high on those outcomes where the previously mentioned outlier studies were included, and more studies had a high risk of bias. If we look at the numbers, we can see that comparing the 2 groups to each other, the CFRD group exhibited higher prevalences by 1–2% in all outcomes. However, this tendency for higher positivity rate in CFRD patients stands without statistically significant difference. So we wanted to test this tendency from a different point of view. Therefore, odds ratios of antibody positivity were calculated between CFRD and non-CFRD patients. In this analysis, the heterogeneity was low and the studies had high risk of bias. The odds of antibody positivity ranged from 2 to almost 5 and was consistently associated with CFRD, with strongest association for gut positivity, where CFRD patients had more than 4.5 times higher odds to have antibody positivity. So in general, higher odds of antibody positivity was found in CFRD patients. This table summarizes our outcomes eligible only for a systematic review, where the overall assessment revealed that an abnormal glucose tolerance presented earlier in islet antibody positive people with CF and with more complications. The strength of our study are that besides prevalences, odds ratios were analyzed, and we conducted a comprehensive analysis of several islet antibodies, including multiple positivity as well. Our limitations are that the included studies had high risk of bias and our results are heterogeneous. So in conclusion, islet antibodies are present in 1 to 6% of people with CF, but despite this low prevalence, islet anti-positive individuals have higher odds to develop CFRD and a possibly increased risk for earlier onset and acute complications. So our implications for practice are that routine screening is not necessary in the CF population for islet antibodies, but a closer monitoring is crucial for islet antibody positive individuals. Implications for research are to refine risk stratification methods and more studies focusing on further beta cell damage prevention. We submitted this work to Diabetes Care this month, who unfortunately rejected us, so we immediately submitted to another journal, Diabetes Metabolism Research and Reviews, and hope for the best. Currently, the submission is being assigned for review. So let's move on to our second project, where we are investigating not just islet autoantibodies, but family history of diabetes as well in our own patient cohort with a registry analysis. And as I previously mentioned, the role of islet antibodies is well established in type 1 diabetes, and the TEDdy study group recently published a combined risk score which enhanced type 1 diabetes prediction. And the best performing model of this risk score incorporated the screening of islet antibodies, a genetic risk score, and the family history of diabetes. However, in the CF population, we lack information about these risk factors contributing to an earlier onset of an abnormal glucose tolerance. Therefore, it is difficult to identify those who are at risk. So with our second project, our aim is to in-depth analyze a possible correlation between these risk factors, islet antibodies and family history of diabetes, and the development of an abnormal glucose tolerance. We will compare children with CF with or without islet antibody positivity or family history of diabetes, and our main outcomes include their glycemic status and the age of onset in case of an abnormal glucose tolerance. And our hypothesis is that there is a significant correlation between these risk factors and earlier abnormal glucose tolerance development. As data source, we are using the previously mentioned CF-related pancreatic disorder registry started at HEIMPA. And from the 137 children included in the registry, 100 were eligible, and with an additional 2 patients from adult care consulted, finally 102 family history were collected. So to summarize our projects, we are investigating or explore potential risk factors of early onset abnormal glucose tolerance in CF patients by first focusing on the prevalence of islet antibodies, and as an extended second project, adding family history of diabetes to the picture. I would like to thank you for your attention with a quote from Jessler: "Children are not things to be molded, but are people to be unfolded."
Thank you for the nice presentation. My question would be for our second project. How do you plan to access the data for the family history questionnaire?
Thank you for your question. We found 2 approaches. One is, I think, the established one in type 1 diabetes. According to the TEDdy study, the family history of diabetes is considered positive when you have a first-degree relative, which means either your parent or your sibling with diabetes. But in CF, there was a previous study where they used a more refined or a broader spectrum and added not just positive and negative to the picture, but a possible group as well. And the possible group is, for example, when you have grandma or grandpa with positive family history of diabetes, and I think we will use that one because it gives a more refined picture.
Thank you for the answer.
Thank you. Any other question from the audience or from the chairs?
Congratulations. Usually, at what age would CF patients show this abnormal glucose tolerance or diabetes?
Well, the screening is recommended from 10 years of age. And I think this is the kind of age where it typically presents. But we see in the clinic children even at a younger age, for example, at 6 or 7 years, but typically 10 years or older.
Thank you. I have also another question. In the typical type 1 diabetic population, yes, there is also possibility to develop autoimmune endocrine disorders, such as problems with the thyroid or the adrenal cortex. So are there studies in the literature that would take those into consideration, or do you see an increased prevalence of those as well in the CF populations?
Well, thank you for this question. It's actually quite a good catch. I think there is a study recently launched which investigated this aspect, and yes, the prevalence of autoimmune diseases was higher, especially I think celiac disease had a higher prevalence in the CF population. And with the questionnaire, we not just tried to assess the family history of diabetes, but we included questions about autoimmune diseases as well. So I'm very eager to see the results.
Thank you.
Maybe not the most gentleman question, but we always learn from the peer review. What was the reason for rejection? Was there any comment on that from diabetes?
Well, I think it was quite a fast rejection, so there was not really a broad comment on the work. So I think they didn't give an exact explanation that that doesn't meet the criteria of the journal, but which was a very positive thing that they said that it could be transferred to another journal, which was suggested by them. So